Are there structural abnormalities in schizophrenia and bipolar disorder on MRI scans?
Yes, there are. And we didn't know that until brain imaging techniques were invented. Thanks to the computer revolution, which started in the 70s, CT scans were developed in the mid to late 70s, and that's when we started doing CT scan research in schizophrenia and bipolar disorder. And then in the early 80s, MRI scans were developed, which are safer than CT scans because they don't have radiation involved. So now all the research in the last 30 years have been done with MRI scans. Now, I did a lot of research on imaging and was one of the first in the world, actually, the first researcher in the world to show that patients with bipolar disorder also have abnormal brains that we initially found in schizophrenia, such as large ventricles, shrunken cortical sulci, and also smaller regions in the brain, especially the frontal lobe or the temporal lobe. So there's a lot of abnormalities in the brain of patients, and they get worse with every episode. Every time the patient relapses, which unfortunately happens a lot, primarily due to poor adherence, they stop the medication, they get sick again, and that's true for both schizophrenia and bipolar disorder. Both disorders can result in more and more brain abnormalities, atrophy, shrinkage. I mean, it can be devastating across the whole brain, and they lose both gray and white matter. And both of them are very serious. You cannot afford to lose brain tissue and remain normal. That is one of the top reasons for disability, and also treatment resistance. Many studies have shown that with every relapse, patients respond less and less to the same medication that used to work in the first episode or second episode. So it's really vital to remind our patients, whether they have schizophrenia or bipolar disorder, please stay on your medication. And if they have trouble with that, I strongly advocate using long-acting injectable antipsychotics, which are available, and they guarantee that the patient is receiving the medication with one injection a month, once a month, once every 2 months, once every 3 months. We have different LAIs, as we call them, long-acting injectables, and the patient doesn't have to worry about taking pills at all. This is my favorite way of keeping my patients well, so they don't have brain damage that you can see on MRI scans.
Are there neurobiological differences and similarities between schizophrenia and bipolar disorder?
Yes, again, they share some biological differences, but not some neurobiological factors, but not all of them. The two factors that are shared between schizophrenia and bipolar disorder is that there is neuroinflammation and oxidative stress. These are two processes that are toxic in the brain. Neuroinflammation means the patient's brain is on fire. It's being burned with pro-inflammatory substances like cytokines, interleukins, TNF-alpha, interferon gamma, CRP. We have a lot of those that we measure in the CSF and the blood, and they are very high during the psychotic episode or manic episode or depressive episode. And then when the patient gets better, they all go down to normal. The other abnormal biomarker is free radicals. We call that oxidative stress. Free radicals are very nasty molecules that literally chew up brain tissue, and they go very high. They're extremely abundant during the psychotic or manic episodes. And again, they subside when we treat the psychosis or the mania effectively. So those are two processes that are shared. Now, there are a lot of biomarkers in the brain and in the serum that are being developed with both disorders that can help us differentiate them. These also include neurophysiological parameters like evoked potentials. They also include motor abnormalities that tend to occur in schizophrenia more so than bipolar disorder. There's also a lot of neurochemical changes in the dopamine, the serotonin, the glutamate system, the GABA systems. All of these have been published, and they're too detailed to discuss here, but suffice it to say that yes, we do have neurochemical, neurophysiological, and neurobiological biomarkers that are helping us with this, not only distinguishing those two, but we're finding a lot of them are actually overlapping, and that is an important area of research these days.
Are there treatments that are used in both schizophrenia and bipolar disorder, and are there treatments that are unique to each?
Yes, one of the very important events in the history of psychiatry is discovering medications for mental illness. Until 1950, for centuries, people believed that if you become mad, they called it madness back then, which we now call psychosis or mental illness, they believed that it's hopeless, that there's no way you can be normal again. That turned out not to be true, because in the early 50s, we discovered antipsychotic medications, which actually led to emptying the state hospitals. Patients were able to get rid of their delusions and hallucinations and go and live in the community, which was a huge, huge event in psychiatry and gave a lot of hope to people. And by the way, 50% of all hospital beds in the United States in 1950 were occupied by a psychiatric patient. You see, and now it's like 9%. So psychiatry was such a large discipline because there was no treatment. So antipsychotics helped get rid of schizophrenia patients, of the symptoms of schizophrenia rather, and it turned out to work in bipolar patients as well, in the manic phase. So the antipsychotics work and are used in both first and in the bipolar and the schizophrenia patient. And I said first and second generation because we have had two different types of antipsychotics. The first generation between 1952 and 1975, and then from 1993 to the present time, we have a different generation that are less toxic to the brain and cause less severe side effects, which means they're more likely to be accepted by patients. Both generations have been used in both mania and psychosis. However, lithium is an ion, it's a natural salt. Lithium was also discovered in the late 40s and early 50s to work in acute mania, but it's not used in schizophrenia. So that's an example of a drug that works in mania and bipolar, but not in schizophrenia. The other type of medication is called anticonvulsants or mood stabilizers. These are actually drugs that work in epilepsy, but were found since the 80s and 90s, we found that they also work in acute mania. These include valproate, carbamazepine, and lamotrigine. Okay, so those are used in bipolar, but not in schizophrenia. What about the depressed phase of bipolar disorder? Again, the best treatment for severe depression is ECT, electroconvulsive therapy. Some people refer to it as shock treatment. It's one of the safest, best treatments in the world for severe depression. But we don't send everybody to ECT right away. We have medications that are also approved for the depressed phase of bipolar disorder, which are also used when patients with schizophrenia are depressed. But there are 3 drugs approved by the FDA specifically for the depression of bipolar disorder that many clinicians have used in the past, antidepressants that are used for major depression, not for bipolar depression. Those are not approved for bipolar depression. But again, 3 drugs have been approved for bipolar depression. We can use regular antidepressants for depressed patients with schizophrenia, but we shouldn't use them for bipolar disorder in the depressed phase because they can switch the patient to a manic state. So there's a lot of similarity, there's a lot of overlap, but also some drugs that are used in one but not the other.
What about the prognosis and functional outcomes in schizophrenia versus bipolar disorder?
Well, there are some differences there. In schizophrenia, studies over the last 80 years have shown by actual following up of the patients, even before the introduction of the antipsychotic drugs in the 1950s, before there were any treatments, they actually found that about 20% of patients with schizophrenia recover completely, okay? without any drugs. Of course, now we have drugs and we hope to increase that percent. But frankly, many patients still get disabled because they stop the medication and their brain loses hundreds of millions of cells every time they relapse. So that is one of the reasons that many patients with schizophrenia become disabled. And they can't work, they can't marry, they can't get a job. I mean, they are truly disabled. In bipolar disorder, the prognosis is better, quite much better in a significant proportion of the patients, but not all. There is a subgroup of patients with bipolar that have severe psychotic symptoms. It's bipolar with psychotic features, we call it. And these patients also have more cognitive deficits than the average bipolar. This subgroup of bipolar also tend to become chronic and disabled. But a good chunk, more than 50% of patients with bipolar disorder actually recover completely thanks to the medications. If they take their lithium, their mood stabilizer, their atypical antipsychotic, etc., they can remain well and go back to work. I have friends who are doctors and nurses and teachers and lawyers who have bipolar disorder. They're extremely talented. They work extremely well. They're loved by their friends and families and their patients because they stay on their medication and don't stop it. So there is a group that recovers very well in bipolar, but there is a subgroup that becomes chronic, and they tend to share more psychotic symptoms and cognitive deficits like schizophrenia.
Thank you, Dr. Nasrallah. We appreciate this discussion. Thank you for your time. If any of our viewers have any questions for Dr. Nasrallah, go to CURESZ.org, CURESZ.org, and click on contact. You can find us there.
Yes, Bethany, we've had several videotapes made for our patients and for our friends who want to learn about serious mental illness. And if you go on CURESZ.org, you can see quite a lot of them in addition to this one. Great talking to you, Bethany, and best wishes for the new year.
Thank you.